This conference will now be recorded.
ఇందులో బయటికి ఏం పెట్టండి.
యూట్యూబ్ లో వస్తున్నాయి కదా.
వస్తున్నాయి మేడం, మన ఆశ్రమం వస్తాయి మేడం.
అదే యూట్యూబ్ లో ఉన్నాయి.
ఉన్నాయి మేడం.
వాటర్ స్టార్ట్ చేయొచ్చు. Good morning, everybody. Today we are going to discuss about pulmonary tuberculosis. I'm Dr. Sravani, second year postgraduate from Department of Radiodiagnosis. Introduction. Mycobacterium tuberculosis accounts for more than 95% of the pulmonary mycobacterial infections. Other mycobacterial species, mainly Mycobacterium canceraceae and Mycobacterium avium intracellular complex, known as MAC complex, account for the remainder. Factors that contribute to the large number of cases seen worldwide are HIV infection, inner city poverty, homelessness, and immigration from the areas with high rates of infection. Other predisposing factors include diabetic mellitus, alcoholism, silicosis, malignancy, immunocompromise from a variety of causes, and living in closed institutions. Immunocompromised individuals and young children are at higher risk of extrapulmonary disease. Typical symptoms of active tuberculosis include productive cough, hemoptysis, weight loss, fatigue, malaise, fever, night sweats. Insidious and non-specific symptoms of active tuberculosis, such as physician must maintain high index of suspicion based on the risk factors. Radiologists can aid in diagnosis by performing imaging examinations, sometimes even incidentally in the absence of clinical suspicion. The immune response to mycobacteria has important implications for the clinical and imaging appearance of tuberculosis, particularly in immunocompromised patients, and are best discussed as primary reactivation and reinfection tuberculosis. In approximately 5% of infected individuals, the immune system is inadequate at controlling the initial infection, and the active tuberculosis develops within the first 1 to 2 years. This category is referred to as primary tuberculosis. In another 5% of infected individuals, the immune system is effective at controlling the initial infection, but viable mycobacteria remain dormant and reactivate at a later time. This category is referred to as post-primary or reactivation tuberculosis. In the remaining 90% of the individuals, the disease will never develop, it will never become symptomatic, and it will harbor the infection only at a subclinical level. It is referred to as latent tuberculous infection. The individuals are asymptomatic and are non-contagious. The host immune response prevents the multiplication and the spread of the mycobacteria. So ఇది స్ట్రక్ అయింది. నెక్స్ట్ స్లైడ్ అవ్వట్లేదు.
ఇలా క్లిక్ చేయాలి మేడం ఒకసారి.
థ్యాంక్ యూ. స్ట్రక్ అయింది. With regard to post-primary tuberculosis, evidence suggests that the patients in endemic areas are more likely to be infected by a second strain of tuberculosis than to experience reactivation of a previously infected strain. In contrast, reactivation causes the majority of the cases of post-primary tuberculosis in developed countries, although a second infection is responsible for a small fraction of cases. The clinical and the imaging manifestations of tuberculosis may be related more to the host factors, particularly immunosuppression, than to the mechanism of the infection. It is more important to distinguish between the active and the latent tuberculosis than to distinguish between the primary and the post-primary tuberculosis. Primary tuberculosis, this form is commonly seen in infants, children, and immunocompromised individuals. Most cases of primary pulmonary tuberculosis are subclinical, although there may be fever, respiratory symptoms, or erythema nodosum. Although primary tuberculosis typically presents with radiological manifestations, chest radiographs may be normal in 15% of cases. Organisms settle and multiply in the alveolus or anywhere in the lungs, but most commonly in the subpleural site in a well-ventilated lower lobes. There is an area of peripheral consolidation called Gons focus, and spread from this along the draining lymphatics may lead to the enlargement of the regional lymph nodes, and the combination of the Gons focus with the enlarged regional lymph nodes is referred to as primary complex. Activation of the immune system usually leads to resolution, healing, and fibrosis at this stage, and usually a fibrous capsule walls of the lesion and dystrophic calcification may occur. When a Gons focus or and ipsilateral lymph node calcification, if they are seen together, the combination is referred to as Rankus complex. This is the Gons focus, and through the lymphatics it spreads to the regional lymph nodes and causes the enlargement of the regional lymph node. This is the primary complex, and these are the calcified lymph nodes in the hilum. If the response to the infection is weak, the disease may progress, and there is a little difference between the lesions of primary and post-primary evolution. This may manifest as further consolidation, possibly with cavitation and bronchogenic spread of infection. Rupture of a cavity into the pleura may cause pneumothorax, pleural effusion or empyema, and erosion into pulmonary vessel may lead to hematogenous spread and miliary infection. Primary tuberculosis demonstrate radiographic findings that include lymphadenopathy, consolidation, pleural effusion, and miliary nodules. Coming to lymphadenopathy, mediastinal and hilar lymphadenopathy is the most common radiologic manifestation of the primary tuberculosis. Lymphadenopathy in tuberculosis typically demonstrate a low attenuation center with peripheral rim enhancement on contrast enhanced CT images. Findings that are due to the central caseous necrosis, the low attenuated center that is due to the central caseous necrosis and with peripheral granulomatous inflammatory tissue. This is a chest radiograph frontal view showing lymphadenopathy and consolidation in a 6-month-old infant with primary tuberculosis. In these radiographs, this is the epi view and the lateral view. In this, we can see bilateral mediastinal lymph nodes, enlarged lymph nodes. Enlarged lymph nodes may press on the adjacent airways and cause pulmonary collapse or air trapping with hyperinflation. Caseating nodes may also erode into the airways, causing bronchopneumonia, and into the vessels, causing miliary infection. The differential diagnosis of the necrotic lymphadenopathy includes non-tuberculous mycobacterial infection, lymphoma, and metastatic carcinoma. In these conditions also we can see necrotic lymphadenopathy. Lymphadenopathy typically involves the right paratracheal and the hilar lymph nodes. Within the pediatric population, mediastinal and the hilar lymphadenopathy may be the only radiological finding. At resolution of the lymphadenopathy, calcified normal-sized lymph nodes may remain. Coming to the parenchymal disease, this most frequently manifests as consolidation, depicted as an area of opacity in a segmental or lobar distribution. There is no lobar predilection in the primary tuberculosis. Cavitations occur in minority of the patients with primary tuberculosis. And when cavitation occurs, it is known as progressive primary disease. The cavitation occurs within the existing consolidation, and thus it doesn't demonstrate an upper lung zone predominance, in contrast to post-primary disease. It appears similar to the bacterial pneumonia, but the presence of lymphadenopathy can be a clue that points towards the primary tuberculosis. Chest radiograph frontal view showing consolidation in the right upper lobe. The frontal view of the chest radiograph, this radiograph is showing left hilar enlargement with perihilar consolidation. Resolution of the primary consolidation is generally slow, taking as long as 2 years, and in many cases residual opacities are seen. After resolution, residual parenchyma scarring can be seen at the sites of prior consolidation in 15 to 18% of the patients, and is referred to as Gons focus or Gons tubercle. Pleural effusion. It is seen in approximately 25% of the primary tuberculosis cases in the adults, with vast majority of such effusions being unilateral. Tuberculous pleural effusions usually result from hypersensitivity to tuberculous proteins rather than frank pleural infection, and therefore isolation of Mycobacterium tuberculosis from the pleural fluid is uncommon. Certain fluid states, such as determining the fluid level of the adenosine deaminase, a marker of monocytes and macrophages, are useful in demonstration of tuberculous effusions. This is massive pleural effusion seen on the right side, right pleural cavity. Tuberculous empymas are typically lochelated and are associated with the pleural thickening and enhancement, findings that represent involvement of the pleura. If not treated early, tuberculous empymas may be complicated with bronchopleural fistula or extension into the chest wall. That condition is called as empyema necessitatis. An air fluid level within an empyema in the absence of instrumentation is suggestive of bronchopleural fistula. After treatment and healing, the residual pleural thickening with calcification can develop, potentially leading to the fibrothorax. These are the axial sections of the CT images showing calcified pleura with lochelated empyema. These are the CECT axial sections showing lochelated collection in the pleura. This is called a split pleura sign. Coming to the airway disease, bronchial wall involvement may be seen in primary and post-primary tuberculosis, although it is more common in primary tuberculosis. Bronchial stenosis occurs in 10 to 40% of the patients with active tuberculosis and is due to the direct extension from tuberculous lymphadenitis by means of endobronchial or lymphatic dissemination. The main radiographic features of proximal airway involvement are indirect, including segmental or lobar atelectasis, lobar hyperinflation, mucoid impaction, and post-obstructive pneumonia. At CT, airway involvement can manifest as long segment narrowing with irregular wall thickening, luminal obstruction, and extrinsic compression. This is PA view of the chest radiograph showing upper lobe collapse. And these are the coronal reformated images of the CT at the level of the central bronchus, showing irregular thickening of the right upper lobe bronchus, as well as the consolidation with air bronchogram in the collapse. Compression of the central airways by the enlarged nodes may cause pulmonary collapse or air trapping. Healing of the endobronchial infection with fibrosis may also result in bronchostenosis. The lung distal to the bronchial narrowing may develop bronchiectasis. In these two cases, we can see tuberculous lymphadenopathy in the hilar, causing the hilar enlargement on the left side. Endobronchial spread can occur with or without cavitary disease and is similar to that seen with the primary tuberculosis, leading to appearance of a typical tree. But after anti-tuberculous treatment, healing results in scar formation, often with evidence of severe volume loss and pleural thickening. Residual thin-walled cavities may be present in both the active and the inactive diseases. These are the CT images. Lung window in a 55-year-old man with post-primary tuberculosis. These are showing non-cavitary consolidation in the left lung with a train bud opacities and various size bilateral nodular lesions. This is the chest radiograph and the CT axial sections demonstrating almost complete destruction of the right lung due to the pulmonary tuberculosis. We can see all this tree input pattern in the opposite lung. Miliary tuberculosis, hematogenous dissemination results in miliary tuberculosis, especially in immunocompromised and pediatric patients. Miliary disease may occur in primary or post-primary tuberculosis. On the chest radiograph or CT image, biliary disease manifests as diffuse 1 to 3 mm nodules in a random distribution. This is miliary tuberculosis. There will be randomly distributed micronodules in the bilateral lung fields. Coming to post-primary pulmonary tuberculosis, this follows the primary infection after a latent interval, however short or long, and is due to the reactivation or reinfection. It is now generally accepted that almost all the primary pulmonary tuberculosis due to the reinfection. Post-primary tuberculosis almost demonstrates consolidation that are predominant in the apical and the upper zones. Nodules and cavitation, the radiological manifestation may overlap with those of the primary tuberculosis, but the absence of the lymphadenopathy, most frequent cavitation and predilection for the upper lobes are more typical of reactivation or reinfection of the tuberculosis. Consolidation and cavitation, bilateral upper lobe. In this radiograph, we can see dense or non-homogeneous opacities in right upper lobe and the left upper lobe. Consolidation in the post-primary infection usually appears in the apex of an upper or the lower lobe and almost never in the anterior segments of the upper lobes. The consolidation is often patchy, nodular, or maybe bilateral. Simultaneously, there will be fibrosis and volume loss indicating healing. Cavitation indicates active disease and is seen in the region of the abnormality in 40 to 80% of the cases. Air fluid levels are unusual but have been recorded in some cases. Progressive infection is indicated by extension and coalescence of the areas of consolidation and the development of the cavities. Reinfection tuberculosis. This is a case of reinfection tuberculosis in a 40-year-old man. CT shows extensive parenchymal consolidation of the left upper lobe with multiple cavities. This is in post-primary tuberculosis in a 50-year-old man. The chest radiograph demonstrates patchy air space opacities in the right upper lobe with a cavitary lesion. This is the cavity. These are the CT axial images showing the right upper lobe consolidation with the cavities. This is also showing a thick-walled cavity in the right upper lobe. Centrilobular nodules. The active tuberculosis often communicates with the bronchial tree, which results in endobronchial spread. Caseous necrosis and granulomatous inflammation fill respiratory bronchioles and alveolar ducts. This manifests radiologically as central lobular nodules and green bud sign. Unlike cavitary lesions and consolidation, central lobular nodules may be seen in the lower lobes distinct from the cavitary lesions. Involvement of the airways and the pleura is less common in post-primary than in primary tuberculosis, but shows similar imaging features. These are the CT axial sections demonstrating consolidation and the green bud appearance. This is a case of the Healy tuberculosis with bilateral upper lobe fibrosis with elevation of both the hyla. We can see the basal emphysema with multiple calcified granulomas present randomly. Heel lesions often calcify because the upper lobes are predominantly involved. The effects of the fibrotic lesion are seen as the trachea being pulled away from the midline, elevation of the hyla, and dissection of the lung parenchyma. Coming to the sequelae, tuberculoma and thin-walled cavity. A tuberculoma may occur in the setting of primary or the post-primary tuberculosis and represents a localized parenchymal disease that alternatively activates and heals. It usually calcifies and frequently remains stable for years. This is a thick-walled tuberculoma, a well-defined cavity, and is present in the right hilum. Larger sections of the CT showing well-defined nodule with dense calcification in the right lower lobe. Cicatrization and destruction of the lung. Cicatrization eclectasis is a common finding after post-primary tuberculosis. Fibrotic response which manifests as eclectasis of the upper lobe, retraction of the hilum, compensatory lower lobe hyperinflation, and mediastinal shift towards the fibrotic lung. Complete destruction of a whole lung or a major part of the lung is not uncommon in the end stages of the tuberculosis. Here we can see destruction of the entire lung in a 57-year-old man with post-primary tuberculosis who presented with fever. In the chest radiograph, we can see marked volume loss in the left lung with cavities with air fluid levels, and a small cavity is also seen in the right upper lung. This is CT axial sections showing parenchymal bands with traction bronchiectasis and mild volume loss of both the upper lobes. With large cystic lesions in the posterior aspects of both the lobes representing cystic bronchiectasis. There is spiculated pleural nodules in the right upper lobe. Aspergilloma. Chronic cavities are often colonized by Aspergillus, and other fungi and mystomas may develop. These are the formation of the large irregular thick-walled cavities, and as these are the CT sections showing right apical aspergilloma in a patient with previous TB. The mystoma material is lying free in the dependent part. This is the mystoma material present in the cavity as well as the nodules are adherent to the cavity walls. Bronchogenic carcinoma and pulmonary tuberculosis often coexist, creating a difficult diagnostic problem. Manifestations of carcinoma may be obscured or misinterpreted as a progression of tuberculosis. Tuberculosis may favor the development of the bronchogenic carcinoma by local mechanisms. Scar cancer, tuberculosis, and carcinoma may be coincidentally associated. In addition, carcinoma may lead to reactivation of the tuberculosis both by eroding into encapsulated focus and by decreasing the patient's resistance. Therefore, any predominant or growing nodule should be suspicious for coexisting lung cancers in patients with tuberculosis. This is a Rasmussen's aneurysm. It is a rare but a complicated condition of the cavitated tuberculosis caused by granulomatous weakening of the pulmonary arteriole. This is the Rasmussen's aneurysm. These are the nodules with the consolidation. Lymph node calcification and extranodal extension. It may occur into the adjacent structures such as the bronchus, pericardium, and the esophagus. These are the calcified lymph nodes. Coming to chest wall tuberculosis, tuberculosis occasionally involves the sternum, sternoclavicular joint, or a rib, leading to osseous destruction and localized abscess formation. Such involvement may occur by direct extension from a pleuropulmonary tuberculous lesion, by hematogenic spread, or from a distant focus, or spontaneous discharge of empyema through the pleural cavity into the chest wall, leading to empyema necrosis. Tubercular spondylitis or Pox disease is caused by primarily by hematogenic spread of the pulmonary infection, and most commonly affects the lower thoracic and upper lumbar spine. The early radiographic manifestations of the spinal involvement consists of irregularity of the vertebral end plates, decreased height of the intervertebral disc space, and the sclerosis of the adjacent bone. These are important. With progression of the disease, there is a tendency towards the anterior wedging of the vertebral body, leading to kyphosis and development of the paravertebral abscess. I repeat this, the early radiographic manifestations of the spinal involvement consists of irregularity of the vertebral end plates with decreased height of the intervertebral disc space, and sclerosis of the adjacent bone. This is paravertebral involvement. These are my references. Thank you. Hello.